Okay, so yeah, thank you very much for giving me the opportunity to talk today. I'll be presenting on our work in the NHS Digital TRE as part of the BHF Data Science Centre and beyond on how we can define and redefine disease using the National Electronic Health Records and sort of steps towards a systematic catalogue of human disease that we've called the Atlas of Human Disease. So a bit about me. So I'm a researcher. I'm a professor of biomedical informatics. I'm based at the UCO Institute of Health Informatics, and I'm also an associate director now at the BHF Data Science Centre, leading on the phenomics team. And my background is computer science, and I'm interested in all sorts of sort of methods on using electronic health records, so the data that are collected during routine clinical care for research. And I have the pleasure of working with a small team of researchers. And there's a picture of us from many years ago from our away weekend in Athens, when we were still allowed to leave the house for different reasons. So I'll be briefly talking about how we can scale the way in which we study disease. So if we sort of take a step back and we think about how most studies are conducted to date, they're often focused on an a priori defined list of diseases that are carefully curated and phenotyped using way. And where we really want to be, given the kind of really widespread availability of the data sets that we have now due to COVID, is we want to be able to study very many diseases at the same time and at a level that is has robust accuracy and sensitivity and specificity. And really, my talk today and sort of the methods and some really preliminary results that I'm going to show is around how this can be achieved. Why do we study a few diseases at a time? Well, it mostly has to do with the process of transforming raw electronic health records into disease phenotypes. So identifying who has a particular condition, when did they get it, and if we can ascertain the severity and the sort of give a particular certainty on that phenotyping algorithm. So phenotyping is a really challenging process. And it stems from the fact that research data are not as well curated as, electronic health record data are really messy and they're not as well curated as research data. So electronic health record have a lot of biases, variable data quality, issues with missingness, and other things that make the process of phenotyping, so transforming the raw data into something that can be analyzed, very, very challenging. Part of this challenge stems from the fact that the building blocks of which, or the Lego bricks of which are used to record information are controlled clinical terminologies. And controlled clinical terminologies such as ICD-10 or SNOMED, have information in a very fragmented way. So just a very simple example, if you want to identify all TB cases in ICD-10, you have to look at across 4 different chapters. So they're not all under infection. And that problem, gets kind of exacerbated the more diseases you want to look at. There's also different levels of resolution. So the sort of the notorious not otherwise specified or not elsewhere classified codes that, again, offer different challenges when you start linking multiple sources together. And finally, all of this information is organized by disease organ rather than by clinical specialty. So it doesn't really directly reflect the way in which care is delivered or the way in which clinical specialties engage with care, predominantly because these data are collected for multiple other reasons rather than research. So we have a really fascinating opportunity now, given the BHF Data Science Centre and the COPE notice and the COVID pandemic, that we can scale all of what we do upwards. And not only in terms of sample size of patients, where we now have sort of the unprecedented kind of 56 million people cohort, but also in the number of diseases that we examine. And this is just an example of the richness of all the available data sets. Work that's led by Chris and Johan of understanding even, at the very basic level, how COVID is diagnosed and what different trajectories do patients follow within the healthcare system. And there's more than 8 complementary sources to triangulate information from. So all of this provides a fantastic resource. What does the clinical phenome look like? So what do clinicians actually record? Coders actually record. So this is n log patients on the left-hand side, and 3-digit ICD-10 codes using, again, the entire data. So these are our admitted patient episodes from HES APC, and roughly 250 million admissions, again, on the entire cohort. And we can see it's quite a diverse picture. There's quite a big long tail of codes, of diseases, of phenotypes, essentially, that get recorded in the human phenome across these national data sets. That, again, gives us sort of a really, really big opportunity to look into things in more detail. So what I talked about earlier, what are we aiming to achieve, is to implement what we call a systematic reference catalog of disease. So can we create a catalog of disease that is computable, so machine readable, that provides reproducible phenotyping algorithms for all the diseases that are currently recorded in electronic health records? So we have a prototype ready of this, where we've essentially taken the 13,000 odd ICD-10 codes and summarized them based on existing work of phe codes and expanding on manual annotations into 5,000 or so hierarchically organized phenotype codes. So this is essentially a really big graph structure where things can have only a single parent at the moment, and it's organized by clinical specialty. So we have roughly 30 clinical specialties and subspecialties that we've extracted from the GMC and other sources to manually annotate and tag all of these. Again, trying to somehow address the challenge of heterogeneity in ICD-10, we've classified ICD codes in 10 top-level mutually exclusive categories. So most of them are a disease, but we've tagged things that are not quite a disease, such as syndromes or test abnormalities or things related to risk factors. So you can easily kind of shift through and exclude phenotypes based on both the clinical specialty and also based on what actually the ICD-10 code it sort of defines. And we've added multiple layers of rich annotation, including links to Orphanet, which looks at the rare disease classification based on existing prevalences, but also increasingly adding sort of what clinical guidelines reference these diseases. How are they manifested in primary care? Are there any drugs associated? And this is sort of work that's coordinated by Harry Hemingway and Alvina Lai and many, many others at the Institute of Health Informatics. This is a snapshot of what the catalog looks like at the moment. So this is just a hierarchy of the cardiology, electrophysiology clinical specialty. It's a hierarchy, and you have parent and children codes, and each code can have one or more ICD-10 sort of associations with it, plus any Orphanet disease kind of links. And usually these are more towards the narrow to broad, because they're the ICD-10 code don't have. So once we have the systematic catalog of diseases, we can start plugging in, and this is sort of where it gets exciting, on various different types of analysis. So the very sort of first sort of analysis that we're doing, this is led by Ana Torralbo at UCL, is to look at the incidence and the prevalence of these diseases because we have this computable kind of machine that we could plug into different analysis pipelines and create incidence and prevalence estimates across different kind of clinical specialties. So this is the 250 odd coronary cardiology / stroke medicine phenotypes that we have associated in the national data. And then we can go further than that and start looking at risk associations. So these are not causal in a sense, but they're more hypothesis generating. And these are hazard rates, again, for the same number of phenotypes for mortality given COVID-19 infection. And you can see that they're quite diverse. And once you're able to kind of drill down into the different levels of the hierarchy, you could start looking at patterns in which can generate more hypotheses. So the idea here is that you have a hierarchical structure that you can iteratively query in order to identify sort of what phenotypes are associated with a higher risk of dying once you have COVID. Again, these are not sort of causal analyses, but they're more in terms of generating hypotheses to go on and then do more discovery science. And finally, we have a phenome-wide association pipeline that we've started using, again, implemented in the TRE, where you can plug this reference catalog of disease to answer any sort of question you might want. So again, this is a phenome-wide association study for COVID mortality. Obviously, this is biased because this is based on ICD-10, which by definition will only sort of all of what we already knew, that all of these conditions were on the shielding list in the original sort of pandemic documentation that was issued, and they're associated with a much higher degree of mortality from COVID-19. So this is just like a really, really short summary of all the sort of cool things that we're working on. I really think that we're at an exciting moment of time in research, both because we have the available data and because we now have the tools to query the data and use the data at scale. And through this project and through the Data Science Center, we'll be able to kind of create this atlas of disease that we can then potentially plug into all sorts of other research questions. So you can imagine that a very early target that we have is doing the converse analyses for long COVID and seeing what are the different conditions that manifest after COVID infection at different time periods, again, scanning across the phenome rather than looking at individual conditions one at a time, and being able to do these sort of high throughput analyses at a much easier and kind of reproducible way. So yeah, thank you very much for your time.
Thank you very much, Spiros, in particular for keeping to good time, allowing us a little bit more time for questions. So if you have a question for Spiros, you can raise your hand or